Dosimetry final. We will have approximately 50 questions. All, of course, multiple choice. So, what pathology would cancers of the head and neck be primarily?
Squamous cell.
Huh?
Squamous cell.
Squamous cell, thank you. Why would we need to put a bite block in? If we were treating a patient, obviously a head and neck patient. Why would we need to put a bite block in? Anybody? Bite block?
Keep the tongue in place or something? Keep the tongue out of the way?
Keep the tongue in place.
Or out of the way?
Or, yeah. So it could be that,
Or in place?
yeah.
Whichever
So if you have a bite block, it's usually to keep the tongue in one place or another. So if you're treating the floor mouth, for example, you want to treat the tongue. So you keep it down. If you were treating the here, then you still want to keep the tongue down because you want to keep it out of the way. Does that make sense? So in other words, you want to.
Is that the same thing that we're using, like a depressor or something that she bites on? It's like like a tongue depressor or something wrapped in.
Yeah.
Pushes the tongue over that way.
That's exactly the same.
Okay.
Yeah, normally, there's a lot of people will use fancy tongue depressors or fancy bite blocks. And there's one here that I got from when I was busily doing something else. And you can see that it actually, what it actually does, I'll pass it around and you can just pass it around. You can see the little pictures on the bottom there. So not everybody can afford or want to afford something like that. So basically you get the wooden tongue depressors, you know, and you get 4 or 5 of them, 6 of them, and you wrap the ends in tape and put something over the top to keep them clean, and you just stick them in.
Yeah, but see, this doesn't seem like it really moves the tongue. It more just seems like it's a bite.
It can be that way, yeah.
So what would you use this one for?
You could use it for the tongue. Because you can use the putty there to make it longer.
Okay.
So you can use
Puts
it
the tongue out of the way.
But you can also use that just to keep, sometimes you can attach them to parts of the head, parts of the mask, so you can actually keep the mouth
Open a little.
still and open. Yeah. But then the tongue depressor also keeps the mouth open. Okay. So why would you immobilize the head and neck? Why would you immobilize a patient when you're treating the head and neck?
They're such critical structures, and they can be small fields.
Yep.
What was that? I missed. Small fields?
And critical structures.
So there's some of these that I asked you in midterm exams, so you should know most of them, or some of them. Large patient, to have a head in a neutral position, how do you do that? If you're treating a very large patient and they want the head in a neutral position, which means sort of like that.
Elevate the head.
Elevate the head, so what would that mean to the head base?
Or to push it in.
You have to have it
Or you-
higher? Okay. Everybody agree with that? Yeah, okay. Treat the maxillary antrum or maxillary sinus without including the eye. What kind of position would the head be in? What position would the head be in?
Extended.
I was gonna say, when you mean extended, which way, yeah. So, you mean extended this way? Okay. Okay. So, scenario for you. We have a patient who they planned part one, but they also planned a boost at the same time. So now we are finishing part one and we're going on to treat a boost. Why is it a good idea to take portal images before you start the boost, or as you start the boost?
Due to possible changes from the initial treatment.
What do you mean?
Physical changes.
What do you mean?
If
What
you're
kind of physical changes?
patient's tissue that you're treating and the area around it.
The area anatomical. So the tumor may not be in the same place, or it might be smaller, or it might be larger, or what?
Other organs around it could have shifted, things could have moved.
Okay. Anybody agree with that? Anybody agree with that?
A higher dose or more dose to a more concentrated area.
No, you're not giving a higher dose. You're giving the same dose, daily dose, to a smaller area. You will eventually give a higher dose to a smaller area, but not around it. Everybody agree with that? Okay. What's a retinoblastoma? Anybody?
Cancer of the retina in babies.
Cancer of the retina and
In babies?
in babies, yep, okay. So what's, just for the heck of it, what would you count the age group for retinoblastoma? Anybody like to join the discussion? What's the age group for retinoblastoma? It's more like birth to a year. It really
I'm
is.
taking a guess.
It really is babies. It really is very little kids.
So it's what? It's
Pardon?
from birth to a year.
Yeah, to one. That's basically, the answer is more general than that, so as long as you know what you're talking about. What's the most common intracranial malignancy in adults?
Brain mets.
Intracranial malignancy is brain. So
Mets.
what's the most common?
She said mets.
Metastasis.
Pardon?
Brain metastasis.
If I had to ask you what the most common primary intracranial malignancy is, what would that be?
GBM.
GBM. Yeah. What's the most common cancer in the US? Anybody?
What was the question?
Skin cancer?
What's the most common cancer in the US? Well, no, I'll give you a choice. Is it breast, lung, esophageal, or prostate? Why lung? Why not prostate? You're right, but why? Why not prostate? How many lung patients do you treat as opposed to prostate patients? A lot more lung or a lot more
Well, for
prostate?
starters, both genders have lungs.
Thank you.
I mean,
Thank you, that's what I wanted, yeah. So it may seem that you treat a lot more prostates, but both male and female can have lung cancers, whereas most prostates are male. I did treat a trans patient at one point. So what do we have to be, as far as field sizes, whether they're large, small, or indifferent? Would we be worried about when we're treating the chest? What is so complicated about treating the chest? What do you have to worry about when you're treating chest?
Heart?
No, I'm not talking, organs at risk. I'm talking just, what are the difficulties when you're treating the chest?
Breathing?
Breathing, thank you. So when you're treating the chest, you have to be aware of what? So when you're making a field size, you have to take into account that the patient is moving, right? You may want them to keep still, but you can't physically stop them breathing. People have tried, but no. So it's the motion of respiration you have to be aware of. Oh.
Thank you. Sorry, there was just so much traffic.
Oh, Lord, she's got donuts again.
There was just so much traffic. I don't know.
Thank you.
Thank you.
But I brought you a present.
Yeah.
There you go, first.
Oh, good Lord.
They're from, I don't know.
Has a dash in it, because I don't
place.
get donuts.
From a donut place?
It's a new donut place.
A new donut
Donuts.
place. Okay,
It's the
thank
only
you.
one in
There's a
Jacksonville.
dash.
Uh-huh.
It's called
Oh,
Shipley's.
let me, that was not,
They're napkins over here.
what?
They're napkins over here.
Oh, that's what I was looking for, thank you.
I just spilled coffee on myself, Mallory.
You're welcome.
Okay.
Now you're gonna smell great all day.
I'll do that for the break.
I spill coffee on myself like every day.
This is
So bad.
2 weeks in a row, we have to stop doing this, ladies.
I'm sorry.
Traffic is crazy sometimes.
Yeah, so if I'm gonna be late, I might as well just be late.
What's that one?
Late.
I don't know.
Have juices in there.
Oh, my.
It's total coincidence.
Of course it is. Uh-huh.
It's the holidays.
It's beginning to look a lot like Christmas.
I'm gonna get a Santa hat for Fred.
Yeah, he deserves one.
And I think I've got green and red beads.
Service, hospitality, integrity, passion, leadership, energy, and yummy. Shipley's.
Okay.
Love you guys.
We know.
Love you guys.
Hmm?
So I love you guys.
Uh-huh.
We love you too, Asia.
Can I just say it back
Yes,
to me? Can I just say
Yes.
it back to me?
Later.
I need to say it full blown. I love
Okay,
you.
I love you guys, but
Follow the butt.
please
You
listen.
can't follow with a butt.
Okay. In that case, I expect you all to get 100% on this exam.
We will, for sure.
That power is totally in your hands.
That's true.
Wait, I gotta pause this.
You want some orange juice or apple juice?
I'll have some apple juice, please.
Okay, I'll pour you some.
I cannot.
I feel like we should all pitch in and get Asia a special apron.
She deserves it.
Late but worth
Thank you,
it.
that's fine. Thank you, ma'am.
Of course. Does anybody else want some?
I'll get some later.
Hmm,
It's good,
it's
right?
actually nice.
Yeah. Nice cold apple juice.
Refreshing.
Which one is it?
Tropicana.
Tropicana. Okay.
Somebody needs to FaceTime you next time you're on the road, and that way you can just listen to the lecture as you're.
Yeah,
Don't
you're
get
right.
Yeah, you won't be missing anything.
And then you don't have to wait.
I'll
You can
rewatch
listen
the
to
lecture.
Yeah, okay.
I'll rewatch it.
Okay. So, breast cancer. What's the rate of breast cancer in the US these days? Anybody know? 1 in what? 8? 8? At least that's what the last statistics say, so. Now, when you're treating the breast, anybody heard of cardiac toxicity? Is this important when we're treating breast?
Say that again.
Cardiac toxicity. What does cardiac toxicity mean?
Undesired dose to the heart.
Yeah, basically, or it's the effect, in our case, it's the effect of radiation on the heart. So is this a problem when we're treating breast?
Yes.
Much of a problem?
Is it more a problem for one side than the other,
Is it?
like left?
I thought the heart was pretty radio resistant.
It is radio resistant, but you still have to be careful. So it is sometimes a problem. Especially obviously if you're treating left side. You can't ignore it. So radiation-induced pneumonitis. What's that? What's radiation-induced pneumonitis? Okay, let's put it this way. What's pneumonitis? So what would be the important considerations to take into account if you want to avoid, or avoid as much as you can, radiation pneumonitis? I'll give you this one.
Treat as small an area as you can,
Treat as small an area as you can. Treat as small a dose as you're able to. And watch your fractionation. So obviously you have to treat an area of the lung. If you have a tumor in the lung, obviously you have to treat it. So you have to treat, as we always do, treat as small a volume as is possible. You treat as low a dose as you possibly can in order to cure the cancer. And your fractionation also comes into it. Why does the fractionation come into it? Radiobiological effect. Remember that? What does the radiobiological effect stand for? Or what does it mean? It means the amount of dose over a certain amount of time gives you this effect. If you increase the dose and keep the same number of fractions, it gives you another different effect on the tumor. If you reduce the dose and increase the number of fractions, it gives you another effect. So you should watch the total dose, fractionation schedule, and the volume. Okay, and I think this one was in the midterm. How do you define the abdomen? What is the abdomen?
Diaphragm to the iliac crest.
So the upper margin or the cephalad, everybody knows what cephalad is? That's the upper margin, or the most, and the superior margin. Where should it be set for the abdomen? The superior margin of the abdominal field. You have the diaphragm. Okay, this one. The diaphragm. Diaphragm moves as you breathe, right? So where should you set your beam, your field? I think we went over this when we were discussing the term as well. So it should go to the superior aspect of the medius of the diaphragm on quiet breathing or on complete exhalation. So if you ask the patient to breathe normally and you breathing gently, then you put your border on the superior aspect, the superior border of the diaphragm when the patient is breathing. Does that make sense to anybody or everybody? Steph, you're looking a bit confused.
Well, because you're saying on exhalation, right, on so I feel like for me, it's counterintuitive, because I would think on inhalation, it would go up,
Yeah,
right?
so on exhalation, it should go down.
I
Right,
think
so,
it's the opposite, I thought. Doesn't the diaphragm pull down to extend your lungs open when you're breathing in?
okay, so that would make more sense to me then.
So when you breathe
so you'd
out,
higher
it shrinks
at-
back up.
Okay, so that, because you'd want it at the highest point, right?
You want it at the highest point, but also you want it on normal breathing. If you were asked if it would be exhalation or inhalation, you would put it on exhalation.
Okay.
But you don't want the patient to breathe that deeply when you're treating them.
Okay.
So on normal breathing, just plain breathing,
Superior at
you put
exhalation.
it on the upper border. Does that make sense then? Okay, good. Kidney tolerance. What's the kidney tolerance?
Is it 1800?
1800. 1800 to 2000. Depending on whether you are also giving chemo or not. So if then they ask you for a spread, it would be 1800 to 2000. If someone gave you 2000, use that. If someone gave you 1800, use that.
What if they give you both?
So what?
What if they give you both?
If it's,
Because sometimes they do.
sometimes they do. Yeah, sometimes they do. So I would give 2000. That's a maximum. Same as the spine is a maximum of 4,500. Yeah. So 2000. Okay, let's go to pancreas. What's the most common area of the pancreas for cancer?
Jesus
Good Lord.
Sorry, I tried to hold it in.
That's okay.
Megan, don't judge me.
Scream.
I tried to hold it in. If you should just sneeze all over the back of your head.
It's okay. I have the old dad one where you just.
Just scream.
Yeah, it pisses Kyle off.
Pisses me off too.
He said that
Okay.
just for 1 second. He wants to strangle me when I do it. So if I get strangled, you know
what
why.
happened?
Pancreas. What part of the pancreas is normally the most common area of the pancreas to have cancer? What's the part of the pancreas?
Head, body, and tail. I'm gonna guess head.
Head, body, and tail. You guess head.
Why not? Seems to be the most active.
You're right.
Lot going on there.
You're right. You are absolutely correct. And you realize what's coming next. Okay. What are the organs at risk when you're treating pancreas? The ones that you really need to be careful of. In the pancreas.
Small intestines.
No. That's not one of the ones where you have a low tolerance for radiation. Your organs at risk. Kidneys, definitely. What else?
Bladder.
No.
No, that's
Too
too far away.
Stomach.
You're treating the abdomen. What is the one organ that you have to be careful of anytime you're treating the body?
Spinal cord.
Spinal cord. Not the spine, the spinal cord. Anything else? Although the liver is radio resistant, that is another one you have to be careful of. The liver. You're treating an obese patient, and you're treating them prone. Don't ask me why. You're treating them prone. Why is that an advantage?
Why is the physician an advantage?
Why is it an advantage to treat an obese patient prone as opposed to supine?
Doesn't matter what we're treating?
Well, obviously, if we're treating the patient prone, it probably would be an abdomen or a pelvis.
Maybe get the tissue out of the
This is a
way.
technical thing about positioning. What?
Get the tissue out of the way. Like if it's falling forward, then
Get the
tissue.
tissue. Okay. Why would that matter?
You'd be treating through a lot of fat.
So if you're treating a patient, you're using the skin marks, tattoos, whatever you're using. If you have an obese patient and you flip them over if possible, get them prone. Are the marks easier to position, is the patient easier to position? Once you get them prone, once you get them prone, is the patient easier to set up using the marks? Why?
Less Joe.
Less jiggle? Let's just say it's less jiggle.
That's not quite the way I would put it in an exam, but yeah, you're right.
Less
It would be
movement.
less movement, less extra tissue, shall we say. I once had a patient who we were trying to get, I can't remember what we were doing, and we put her arms up and we're trying to, and she had some extra skin, extra tissue. And I said, we're just going to get the extra tissue out of the way. And she said, no dear, it's fat. So, yeah, extra tissue. Apart from the fact that it moves a small bowel and everything else. Okay, so we're treating the same pelvis, or we're treating the same obese patient, supine. What would be the concern about that? So you've got an obese patient that she physically cannot lie prone, so you have to treat her supine, or him supine. What are the difficulties? What's the main difficulties of position of?
Clearance.
Pardon?
Clearance.
Clearance?
Yeah, you have to set them up just right.
Why?
Because if not, then you have to go in the room and make sure you're not gonna hit them.
Oh, you're thinking about,
Like if you don't get them set up just right, you might not clear.
you might not clear, okay. She says from,
Spirit.
hopefully somebody else is moving the machine.
Nobody hit them, but it's just like, oh shoot, we're really close. We gotta go in
Yeah,
now.
okay. So, apart from that, what is the problem with actually physically setting them up?
The movable tissue.
Your marks, are they going to be correct? The skin marks? You can make them move any way you want, especially the front, the anterior ones. You can move the belly any way you want. So yeah, reproducing the patient's positioning out. That is, and much as I hate to treat patients prone, that is really the one thing that works. So when we were doing the cervix, when we were doing gynecological treatments, going over them last week, we discussed if you have to treat para-aortics with the pelvic fields. So you'd end up with what is basically this. Oh dear. That. This is the pelvis, this is the para-aortics. Okay? So, do you treat this separate fields, or you treat it in one or together? So in other words, do you treat the para-aortics and then the pelvic fields, or do you treat it in one big field? And if you do, why? Why would you do two fields or two separate areas? And conversely, why would you treat in one area?
Depends on the patient's size.
What do you mean?
Smaller person like a child, probably do it.
No, I mean, we're not talking really large fields. We're talking from here to here. So it's doable on any patient.
Just use your MLCs to carve out the dose.
Yeah, okay. So you're shielding. Right? So that's not exactly why.
This is
doing that.
fantastic drawing.
So is there a reason why we would split them? Treat the pelvis first, and the paraortics next? Or is there a reason to treat them both together
If you treat
in
them
one
both,
big field?
if you treat them both together, then you don't have to worry about the line, the matching line every single time.
And that junction,
Yeah.
that's what I'm talking about. Yeah. That's the reason why you would do it in one area. Because you don't have to worry about overlap or underlap or whatever it happens to be. Okay, so has anybody seen a prone pelvis treatment? Was the patient a rectal patient? So why do a lot of physicians treat rectums prone?
Just to get her small bowels out of the way.
Get small bowel out of the way. Okay. What about skin reactions?
It's gonna happen.
It's gonna happen, yeah.
On your butt.
Yeah.
My husband just noticed his
Oh.
the other day.
What?
My husband just noticed his the other day. I was like, you have had this for months.
Skin reaction on his butt?
Yeah.
Reaction in butt.
Yeah, like on the skin.
He doesn't look at his butt in the mirror?
Apparently
And
not.
he was
I look at my butt every
He was
day.
treated supine.
Yeah.
So, if the patient is treated supine, where is the reaction? It's usually in the natal cleft, which is between the buttocks, right? Because remember, anywhere there's a fold, you get more reactions. That's why the ladies always have a little bit of a reaction underneath the breast when you treat the breast, because there's a fold there, you can't avoid the fold. So if you're treating the pelvis, and this happens with either rectum or bladder or prostate or cervix or whatever it happens to be, if the patient is supine, the worst reaction is going to be in between the buttocks because it's a fold, and in the groin because it's a fold. So the most common reaction when the patient is supine is in the natal cleft, in between the buttocks. So if the patient is prone, would the reaction in the buttocks be better
It'd be less.
or more, or, sorry?
It'd be less.
It would be less.
I have a question.
Gravity.
So we've had,
Pulls it apart.
a larger patient that had to have, she was supine pelvis.
Uh-huh.
And she had to have rolls of gauze put in between the creases of her thighs. What exactly does that do? It didn't seem like it's keeping anything apart.
It opens it up a little bit. So is it in the groin she was
It's
having?
deeper down, but then her skin just kind of folds over it, you can't even
Yeah.
see it, it just disappears.
It's an attempt to try and open up the groin.
We thought on the FUPA trials.
We had a
No.
It was
Yeah.
covered in like
No.
mud. Like,
And it does.
like halfway through, they had to just redo her plant supply because like it just didn't line up good at all. Like every day, it would just be so bad.
Probably because I did it.
Okay.
No, it was just like, she wasn't really, she was swelling, so that could be part of it, but I don't understand why, like, supine was any better, but
Was she,
it was just lining up terribly every day, so their doctor was like, I'm not doing this anymore, like, we're just gonna change it.
there was a better plan supine?
Yeah,
Or at least it was better, easier to set up
Yeah.
supine?
it lined up way better, but it was just so weird. It started
That's-
off great, but then it got awful.
Yeah, that's unusual, shall we say. Because normally if you put the patient prone, it keeps the belly in place. You have the, were you treating her on a belly board?
Mhm.
Yeah. So with the belly board, it usually is much easier to position than the prone. Because there's no, the belly tends to be flat, so there's more stable. Unless you're really skinny, unless you have a really skinny patient, that the hip bones are sticking out, and you put them prone, and they're unstable because they're so skinny.
So the belly board, does it have a cutout for the?
Yeah, it has a cutout, yeah.
I haven't seen that. Is it on an angle or it's flat?
Oh, remind me when we come back from break, I showed the ladies some photographs you had gone by that time. So I'll show you the photographs afterwards.
It was just really weird.
Weird, it is
Everything
very
about
weird.
her anatomy was weird.
Was hers cut out? I mean, it was, the one she was on
Did
was
she
cut
have
out?
a very expanded belly?
No, she's really petite, she's small, but like, she had a lot of like abdominal swelling, so,
Yeah.
you know.
Well, I'm just gonna say if she was petite, maybe that's what it was. Sometimes with the petite, they rock when they're lying prone.
It
Because the
started off
hips,
so good, it's like
Yeah.
halfway through, it just got crappy, and we're like, we can't do this.
so, that patient aside, normally the buttock is a much easier position once you get the patient on there. The buttock reaction is less. Where would the reaction be worse if you're treating them prone? When we treat them supine, the reaction, the most brisk reaction is usually between the buttocks. We treat them supine, where would the most brisk reaction be? In the groin.
So wait a minute, you're saying if you treat them prone, then the worst reaction would be in the groin?
Yeah, because you've got entrance and exit
down.
noses here.
So if they're laying on their stomach,
They're laying on their stomach, because with the buttocks, you can actually take the buttocks apart, so that makes it easier. And the only other folds that you have, because you're lying prone, everything's flattened down, is groin. Okay. We're now going back to gynae tumors. What's the most common type of gynae tumors, gynecological tumors? I'll give you the list we have here. Benign ovarian cyst, adenocarcinoma of the endometrium, squamous cell carcinoma of the cervix, and squamous cell carcinoma of the vagina. Which of these tumors is the most common type treated with radiation therapy?
Be the cervix.
Yes. So, I touched on this a couple of weeks ago. We may just have to do a little bit extra. I'll read the question to you. A central pelvis shield is sometimes used in the treatment of opposed ant and posterior fields following intracavitary irradiation. Why do we do that?
Can you repeat that?
I was gonna ask the same thing. Say what?
A central pelvic shield or shielding is sometimes used in the treatment of opposed APPA fields following intracavitary irradiation. Why?
So shielding after?
You've treated intracavitary brachytherapy on this patient. But then the doctor decides, oh, we have to give some more, so we'll do it externally. So we're doing an APPA field. Why do they put a central shield down the middle of the field?
Because you've already treated that area, so you're controlling the dose.
Okay.
I'm just guessing. That would be so familiar to me. Did we go over that already?
We did. I think it was one of the days when there was a few people off. Okay. So, to protect, so what areas are you actually trying to protect then?
Cervical.
No, because you're actually you will incidentally treat that, yeah. So it's actually protect also the organs at risk, which are, we're treating cervix, what are the organs at risk? Or if we're treating any gynecological patient, or any gynecological area, what are the organs
Ovaries.
at risk? Rectum?
Over.
Rectum.
Rectum's not an organ, is it?
I think.
What else?
technically.
Bladder?
And
Ovaries. But they're not like really central.
no, you wouldn't want to treat them, you don't want to shield the ovaries. They may be incidentally shielded, but it's usually bladder and rectum.
You said there was a third one?
Say again?
You said there was a third one?
Did I? Sorry. No.
Oh, you said what
I
else?
did
So,
what else, yes.
you know, I just assumed.
So, how do you reduce the volume of small bowel that you're treating if you're treating pelvic field? Belly board? Belly board with the patient how? From. Yep. Anytime you put the patient prone, you're dropping the small bowel. But if you put the patient on a belly board, because of the gap in the belly button, small bowel goes out of the way completely. Okay. Okay. What does GTV mean? And I don't want gross tumor volume.
No.
Okay, so what, if somebody asks you what you're including, what is including in the gross tumor volume?
Tumor.
Hmm?
The tumor.
The tumor, anything else? No, you're right. Gross tumor volume is basically the tumor. Or the visible or demonstrative tumor. Okay, CTV. What does that include?
GTV plus certain set of margins.
No. That's the PT. What is the
Inside the
CT?
CTV?
Pardon?
There's nothing inside the CTV, is that the smallest one?
No. The CTV is larger than the GTV. So the CTV includes the GTV plus what? Pardon?
Notes.
The nodes, thank you. Any lymphatic or microscopic or subclinical disease. And then the PTV, this one, PTV is not in the test, but the PTV is the GTV plus the CTV plus plus a margin. Okay. So field size when using an SSD technique. Where is the field size defined? If you're using an SSD technique. So if you're using a 10 by 10 field, you've set 10 by 10 on the collimators. With an SSD technique, where would you be able to measure that 10 by 10? Anybody care to guess?
On the surface?
Pardon?
On the surface?
On the surface of the patient? Yeah, that's right. SSD is 100 to where? To the skin. So if you set a 10 by 10 on the collimator, you would measure a 10 by 10, the light field on the skin at 100 SSD would be your 10 by 10. This is with an SAD. This one's not on the test. An SAD technique, you set your 10 by 10 on the collimator. Where would you measure, or where would it be measured at 10 by 10? SAD, isocentric patient. Where's the 10 by 10 measure? It's not on the skin because that's SAD, that's SSD. What's SAD?
At the axis?
At the isocenter, yeah, at the isocenter. At the skin, it would be more or less. You set a 10x10 at isocenter, SAD, and you measure the field at the skin,
Should be less.
it would be less, yeah. Because your 10x10 is measured somewhere in the middle of the patient. Okay. Treatment planning CT or radiation therapy CT. What's the difference between a diagnostic CT machine? Excuse me. What is the difference between a diagnostic CT scan and a treatment planning scan?
The couch,
What about the couch?
diagnostic is curved,
Diagnostic is curved
and
and the therapy one is
flat.
flat. Okay. So what else about that? If you send the patient over to get a CAT scan in the hospital, and it's not going to be a treatment planning scan, it's something that the doctor wants to check on something completely different. How is the patient positioned? Don't know, depends on the person doing the scan. It could be feet first with their arms above their head, it could be head first with their arms down by their sides, it could be anything. How is the patient positioned for a therapy scan? For a treatment planning scan in the therapy department?
However, they're going to be treated.
They have to be treated, they have to be scanned in the position that they're going to be treated, and they have to be scanned on a flat surface or on the table that is exact duplicate of the treatment table. That makes sense? Good. Okay. 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 One more question and I'll let you go for a break. So when you do a contour of a patient, normally these days, the CT does the contour, right? CT, as long as you get the whole patient in the scan, the contour can be checked from the scan. Is it important, the shape and the size of the isodoles? Does it make any difference to the plan?
Can you repeat that?
Yeah. When the scan is done and the contour, you see the contour on the patient from the CT. Is it important that the scan, or excuse me, is it important that the contour is the correct shape of the patient and the correct size of the patient? Is it important to the plan? Why? Why is that important? If your shape or the size were incorrect, what would that do to the plan?
You're gonna treat what you don't want to treat and not treat
Yeah.
what you want to treat.
Yeah, it would be inaccurate would be the correct phrase. It would have an effect on the dose, it would have an effect on the positioning of the patient. Okay. 10 past on this clock. Let's come back at 10:30 by that clock. Oh, may I have some more apple juice?
No.
Thank you.
I'm at number 30 on my paper, so more than.
Actually, should be 31.
Oh,
Somehow I'm at
sheesh.
36.
Oh, no, you're right. I am at 31.
Yeah. So we're going to do 32. And we've got 53 in it.
53. You said 50.
I said approximately 50. Don't worry, we'll get finished in time.
Every time I say something,
And maybe a little more besides.
She's misleading
Just
us.
look her out.
What?
What's that?
So she's misleading us.
Okay, let's start again. So, you've probably noticed this in your clinic, that sometimes the way that the CT images are, excuse me, no, let's start again. The way that the patient is positioned in CT, you get him or her on the table, and it doesn't always work. Have you noticed that? No? Doesn't always position as well as you would think so, coming straight out of CT. The marks don't fit, the patient is kind of crooked. No? Have you noticed that? No?
He has gone back in and repositioned,
Yes.
you know, that, when he's looked at the monitor before they take the scan. Is that what you're talking about?
No, I'm talking about how the patient is positioned in CT as to how the patient is positioned on their first day of treatment.
Sometimes we have to change minor things.
Yeah. So what might it be? What might that be accountable to? Why does that happen, do you think? The bed's the same, right? Nobody has a CT. Does everyone have a CT in their department? So you don't have to go across to the hospital to have one done, or to the imaging center to have one done.
You have to go across hospital.
You have to go into the hospital.
Well, we're attached to the imaging center.
Yeah, I know you are, yeah. So, but no, the CT, the treatment CT, is it part of the imaging center, or is it part of the treatment center?
You have to go to the other side of the building, which is the imaging center. So I'm assuming it's part of the imaging, but we use it.
So, that's the other thing. So, does the bed have to be altered?
Yeah.
When you go into the CT, does it have a treatment style bed, or does it have a top, a flat top that goes onto the curve?
Maybe.
We have to put a flat top on.
You have to put a flat top on, okay. So if you have to put a flat top on, then presumably it's the same flat top as the bed is, as the treatment bed is, right? Okay. So anything else that it could be? When the patient is CT'd, what are they wearing? Say we are treating the pelvis. How do you position your patient in CT, or how is the patient positioned in CT? In what kind of clothing is the patient positioned in? Do they strip off and get a gown on?
Sometimes.
Sometimes. Why only sometimes?
Well, if they come in wearing jeans, we're like, okay, we might as well just change them, you know? But if they come in like in sweatpants, we'll just have them pulled down.
And that's the same in CT.
That's what I'm saying, for CT.
Okay. So they're wearing sweatpants, so you slide them down. What about next day they come in for treatment, or 2 days or 3 days after they come in for treatment? What are they wearing then? They wearing the same sweatpants? And how far do they pull the sweatpants down? What's underneath the bag? Do they have a shirt on when they did the CT, but they have a sweater on when they do the treatment? Get my drift here?
First day
So what are we saying? So what are the discrepancies? What are the discrepancies between doing CT and doing the first treatment? Different people, right? The therapist in CT, is it the same therapist that does the treatment? No, it's different people. That's why a lot of centers say, we put a gown on. I don't care what they're treating them, we put a gown on. And they put a gown on for treatment, so that they have the same clothing. Because think about it, if you have a t-shirt on when you're being CT, and then you come in 3 days after or 4 days after for your first treatment, and we have a cold snap, and you have a sweater on, is that going to make a difference? Yeah.
Yeah, they just say to take it off.
Take it off. So therefore, it's easier if everybody has a gown on. So it doesn't matter what kind of clothing they have on. What about shoes? And you're CTing the patient. If they're being CT'd for pelvis, do you keep the shoes on? Take them off? Off. What about treatment? Take them off. Okay. At least that's one thing. So what we're trying to say is the discrepancies could be not necessarily the bed, because even if it is a flat bed, had to be moved on. The beds should be the same. What about the laser systems? Are they different? The laser alignments, are they the same in CT as opposed to treatment? If the department has a CT of their own, it should be exactly the same. If, however, you go to a diagnostic center, whether it's the hospital or the imaging center, the lasers may be slightly different. Or the laser systems may be slightly different.
That seems like it'd be a big issue.
Huh?
That seems like it'd be a big issue.
Well, as long as you can get a laser light to match your marks, then it probably wouldn't be a big issue. But most, if you're gonna use the diagnostic CT for treatment planning, then they should have the same lasers as the therapists do. Okay. So maybe lasers, maybe clothing, maybe a different couch top. Okay, on that vein, I'll read this to you. Uncertainties associated with delivering radiation therapy can be totally avoided by. How can you avoid uncertainties when you're treating the same patient every day? Is there anything you can do to avoid errors when you're treating the patient every day? Let me read you the answers. Having the same staff treat each patient daily, daily machine calibration, and using vigorous patient mobilization. Number 2, having the same physicist calibrate the machine daily, using vigorous patient mobilization, and taking port films every day. 3, daily machine calibration, vigorous patient mobilization, and using CT for treatment planning of all patients. And D, no special means, since there is no method by which all uncertainties can be avoided.
C? I think C.
Yeah. We'll see. What?
It
What was
had
C?
the most information
C
in it.
was daily machine calibration, vigorous patient mobilization, and using CT for treatment planning of all patients. Does that totally rule out any uncertainties? No,
No.
none of these rule out uncertainties. And you certainly, if you suggest to one physicist that he was to do the calibration on each machine daily, you'd be thrown out in your ear. Or you get talked to rather loudly. No, there really is no way to avoid.
So then the answer is the last one?
C, not the last one. The last
She
one.
just said that the
It
last
is
one.
D.
D, I thought D said there is. Oh, you're saying there is no. Okay.
Oh, so it's D? There is no?
So what would we have to do to
She definitely said yes.
to make sure that there was no method by which all uncertainties can be avoided. What would we have to do to make sure that the patients, nothing untoward happened to the patients? Absolutely nothing untoward happened to the patients. Think about it. What would we have to do?
Your best.
Patients would have to be cocooned into somewhere where they couldn't move. And we would have to be absolutely positively sure that the machine, not that it's not working, that it is always working correctly, but nothing ever happened. No fault ever came out on the machine. Has anybody seen faults on the machine? Very seldom do you get through a day without one fault. So you'd have to make sure that there was no faults ever on the machine. The patients would not move. That the electricity we wouldn't have a surge of electricity. That nobody would talk to us while we're treating the patient. Have you ever had that? You're busy concentrating on watching the patient and some physician or nurse comes in and says, I need to talk to you about so-and-so and so-and-so. And you're talking, I'm really pushing the patient, talk to me like that. Any outside influence had to be gone. Do you see how silly it sounds? That absolutely nothing would have to go wrong. And everybody's human. Much as the doctors would like it to say that they weren't human, they don't make mistakes. They do. That the dosimetrist doesn't make a mistake, the nurse doesn't make a mistake, the physicist doesn't make a mistake, the physician doesn't make a mistake, the therapists don't make mistakes. So the answer's D, no special needs. Okay. When we're treating a patient, we always allow a margin around the tumor, around the treatment area. Why? Why do we allow a margin? What is the margin supposed to do?
To make sure you get all of it.
It's allowing for, yeah. So you're
Microscopic.
talking about the tumor?
Yeah.
Yeah, okay. What else is it allowing for? So why are you worried about a margin? Because you know where you're going to be treating. So why is there a margin around the tumor? Are you going to miss?
Movement.
Movement of what? Of the patient?
Yeah.
Okay, so we've got the margin because the patient may cough or sneeze or breathe heavily or whatever it happens to be. What else?
Movement of the tumor itself.
Movement of the tumor or the areas around the tumor. Yeah. What else?
The errors in positioning.
Errors in positioning. Not, of course, that it happens often, but yes. What else? Errors in positioning could mean that the patient's supposed to have a full bladder, but it isn't quite full, so it alters where the tumor is. So uncertainties would be patient movement, changes in the tumor, that type of thing. That makes sense? Okay. Okay. So everybody by now, perhaps, maybe, has made an electron cutout. Has everybody seen an electron cutout made? Yeah.
I've seen them draw like class.
Okay. So, where is it done? Where is it made? Do you have a special room? What's so special about that room? Has anybody mentioned to you what's so special about that room? Is there anything specific in that room that is different from anywhere else? We should have special ventilation, because what are you doing when you're making that electron cutout? You're working with what kind of
Lead?
Pardon?
What type of lead?
It's melted,
Oh.
right? So you melt cerebend, it can give off some fumes, hence the ventilation. What else is there about cerebend? Not so much since we've stopped making photon cerebend blocks. But if you drop one on your toe, you'll know about it. Even the little, apart from the fact you probably snap it, but if you drop some on your toe, or when you're pouring the cerebend, what happens if you miss? It goes all over the floor and all over your feet. What else does it do?
It'll mess up the process of like if you mess up the pouring process and it's not like continuous, then it'll mess up the thing.
The other thing you also have to do sometimes is that when you pour the cerebend, before it goes into the electron cone or electron cutout, you might have to use a rasp in order to clean it up. What does that do? It gives you pieces of cerebend lying around the counter. Has anybody done that? So there's no eating in the room, the block room, or call it what you will. What are they calling it these days? Is that a block room? Okay. No eating, no drinking. There used to be no smoking as well, but that's gone by the wayside because nobody's allowed to do that anymore. You should have decent, of course, everybody has decent shoes on, right? You should have decent shoes in case something falls off the counter. Or the molten metal drips onto the floor. or you get it on your fingers, that's nasty. So, proper ventilation. Wash hands before eating if you're eating after. Wash your hands. It's also a good idea to wear gloves. Sometimes they'll have special gloves in there. If not, use the normal examination gloves. At least it gives you some support. I think we'll probably need to be 50. Okay, when we are treating a lip, has anybody treated a lip? Okay, think about this. If we are treating a lip, what are you worried about inside here? If you're treating a lip here, what's inside here? Mucosa? What can you do to avoid treating the mucosa? Is there any shielding you can put in there to not treat the mucosa? What treatment are you going to do? What machine are you going to use to treat the lip? It's treated like skin. What treatment are you going to use? Electrons, yeah. So how do you shield from an electron beam? How do you protect the mucosa when you're treating electrons? Anybody? Have you ever had the time when you're treating with an electron cutout? The doctor comes in and looks at it and says, I think we need a little more shielding. What did he use? If you've got an electron cutout like this, I'll show you.
Is that pink stuff?
Relax.
Thank you. You said that. So you have an electron cutout like that, and the doctor comes in and says, well, here's the electron cutout. The doctor says, I don't like that, I need to shield this part. So you're gonna make a new cutout for tomorrow. The doctor wants it treated today. What do you use? Lead, yeah. So you get a piece of lead, there's usually some of it lying in the department. And you put it on the, just on top of the cutout. Covered with lead, covered with wax. Because wax will absorb the lower energies. So my question still stands. If you want to you're treating here and you want to shield mucosa behind here, what do? You shield it with lead covered in wax. And you put it inside of here. Does that make sense? Okay. A little easier one. What do you use bolus for? Come on, guys, what do you use bolus for?
Bring the dose to the surface.
Not quite. You're on the right path, but do we always bring it to the surface? You want to bring the dose up closer to the surface. So we don't always need to bring the dose completely to the surface, you just want it closer. Does that make sense? Okay. Everybody know what that means, right? Okay. And that would be altering what? If you have a 6 MV beam and you put a 0.5 centimeter on to the top of the patient's skin, what's that altering? Dmax, yeah. So Dmax for a 6 MV beam is 1.5 centimeters. So you put a centimeter, you put 0.5 centimeter of bolus on top. That means your Dmax is now 1.0. So you're altering Dmax. Portal images. Most of the time, the frequency that you do the portal images vary, or varies. But how often should they be taken?
At least once every 5 fractions.
At least once every 5 fractions, yeah. Should they also be done okay, no, that's fine. So, treatment parameters. Does everybody know what I mean by a treatment parameter? So field size, or a field, a portal, or a field. How do you document what field? You have lots of options. You have tattoos, you have photographs, you have drawings, port film, portal image. How do you document field? So you could do a tattoo. Photograph each field and take a port film of each field. Anybody taking portal images of, let's put it this way. Anybody doing non-IMRT fields. You're all doing IMRT fields. Nobody's doing anything else other than IMRT. Mostly. So is there any patients that you would not be doing IMRT on?
If their insurance is not approved by MRT.
Yeah, okay, yeah, yeah. So if they're not IMRT, do you do a portal image of every field at one point or another? Yes.
Yes.
Yes? Yes. So that's how you would document a field. You may take a photograph of the field. More likely you would take a portal image. Okay. 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 Oh, here's a scenario. If a 30-degree wedge is left out of the treatment during 2 of the 5 treatments, would the dose be decreased or increased? Would the isodose distribution be affected? Would the isodose distribution be affected? Okay? Because you've left the wedge out. What about the dose? Would it be increased or decreased?
Increase,
Why?
because your wedge isn't there.
Because your wedge isn't there, yeah. The dose was calculated for the wedge being in. But if the wedge isn't there, the dose you're giving them is higher than it should be, so the dose is increased. Okay, that being said, if an error is discovered, especially a dose delivery error, what's the first thing you should do? Apart from say a few bad words. So what is the first thing that you should actually, what are the steps that you should take? Put it that way. If you either find an error or an error happens as you're treating the patient, what's the first thing you should do?
Bring it up.
Stop treatment. Have you already stopped treatment?
Normally, it's already happened by the time you find it.
Bring it up to somebody.
Tell the lead. Okay, I'll take that. Tell your lead. What would he or she do?
Tell the doctor.
Tell the
She
Okay, what would the chief say? What would the therapists, who would the first person the therapist have to with?
Without a doctor.
The doctor. Yeah. That's the first person that you should tell. But in your position, yeah, you're exactly. Tell the lead, and she would probably say, oh, and tell the chief, and then the chief would go. And depending on who found it, usually it's the person who finds it has to inform the physician. So if a junior therapist, for example, finds it, then they would probably go to the lead or the chief and say, you know, I found this, would you come with me to Dr. So-and-so and, you know, tell them? Because it may be the first time you've ever had to do that.
Who gets sued? The doctor.
What?
Who gets sued? The doctor.
What?
Who gits sued?
No.
Nobody.
It depends on what it is.
Hospitals, so I got insurance.
If, for example, you notice that if you have a patient who
I'll sue the doctor.
has got bolus on alternate days, and you were off yesterday, and you come back and Mrs. Jones says, by the way, they didn't put the stuff on that I was supposed to get yesterday. Was there something wrong? And you sort of, oh, well, I was off yesterday, I'm not sure what happened, but you're due for it today anyway, so we'll put it on. So you have actually found the error. Nobody who treated her yesterday noticed. So you're the one that should write the incident report, tell the physician, and then write the incident report. Who else should be told after the physician? This part is not on the test, just who gets told first. Who else should tell? Who else should you tell?
Physics.
Pardon? I'm sorry, physics or dosimetry.
Yeah, I said physics, but you said both, so that's gonna
Yeah.
let you take it.
Either physics or dosimetry, usually dosimetry because they have to do the work. And then the physicist has to check it. So doctor, dosimetrist, patient. No. You let the doc deal with that. You don't tell the patient anything. So there's certain things that, there's certain errors that you can make up. There's other errors that you can't. It's supposed to be there, and it's a physical wedge, so you have to actually physically put it in. And for some reason, it got left out. Theoretically, dosimetry could say, okay, use a 30-degree wedge tomorrow, and that will alter for the 15-degree wedge that you missed, because you put the 15-degree wedge in today and a 15-degree wedge in for yesterday's miss. That's theoretical, but they probably have to plan it all anyway. So you wouldn't be very popular with the symmetry. Doesn't matter what happened, you wouldn't be very popular with symmetry. Okay. So treatment fields. How are they labeled on the treatment machine, on the treatment plan? When you're looking at the treatment page on the computer, how are the fields labeled? You're treating a pelvis, for example. How are the fields labeled? And this is probably better if it's a non-IMRT, because the IMRT ones are usually just ARC 1, ARC 2, ARC 3, right?
You're talking like A1, A2, A3.
So there's no, this is for an IMRT?
Either.
Okay. So if you're doing a non-IMRT, like a 4-field box, APPA, two arrows, would they be labeled AP pelvis 1?
Usually it's just APPA, left, right, left, lat,
So
right, lat.
no right lateral pelvis or AP pelvis or something like that?
It'd just be like APPA, left, lat, right, lat.
Oh, okay, so there's no
And they might put that, I guess it depends who's doing it.
distinction as to whether it's an abdomen or a pelvis or a chest or, No,
Well,
just APPA, right and left lateral. Yes?
We'll put out.
Okay,
Like,
At the top of the treatment.
it's all discussion.
okay, yeah,
How do you
okay.
measure the field?
it'll be like on the, like the treatment, like screen, but not in the title, like not in the, when you're clicking the field, it won't be.
Yeah,
Or might not be.
okay. So, do you also have 1, 2, 3, 4, which would be an APPA right and left lateral? No? What if the patient's had the treatment before? Sometimes what they'll do is they'll put 1, 2, 3, 4, and then if the patient comes back, it'll be field 5, 6, 7, 8, and then if the patient comes back, it'll be field 9 and 10, or 11 and 12, or 13, 14, 15. No? Yes? Sometimes? Okay. So normally it should have a number, a unique number, and a description of what area you're treating. So 1 AP or 3 AP or whatever it happens to
Are you
be.
talking about on the imaging or just like on our list of fields? Like,
The list of fields.
see, ours just has like, it'll have a number, but it usually has like 1, and then it has the gantry
The gantry angle.
angle. And that's
Okay.
it. So we'll know,
Yeah.
you know,
Okay.
but it will say field 1, and then if it's a sub, it'll say field 1, sub 1, sub 2, sub whatever.
Yeah.
But it doesn't really, now on the imaging, if I go back and look at the imaging of the actual field, it gives more description.
Yeah. No, what I'm talking about is actually the fields you are treating. Normally they're labeled LEO or RPO or APPA, whatever it happens to be. So it looks like we're on to brachytherapy. What's afterloading? An afterloading technique? What's that? Anybody? What does it sound like?
So when you put the catheter in, if the catheter's in or something, and then you put in the,
That's what it is now, yeah. When afterloading first was thought of, they put dummy seeds in, took films, took the dummy seeds out, put the actual seeds in, or the tubes or whatever it happened to be. So why did they start afterloading? Because the personnel who were doing brachytherapy were getting a lot of exposure. So afterloading was developed first and foremost to save the staff from getting exposure or getting too much exposure.
so is, when they put the seeds in for like prostate, that's not considered afterloading, is it? The ones that stay?
No, because the seeds that you put in are loaded
When you,
when you get them. So do you remember me mentioning what type of shapes that the sealed sources came in. There was tubes, there was seeds, there was needles, there was ribbons, whatever, right? So remember what a tandem and ovoids was used for. What were tandem and ovoids, or are tandem and ovoids used for?
GYN.
Pardon?
GYN.
GYN, okay. And what shapes are used in tandem and ovoids? The shapes of the radiation sources. Are they seeds, are they needles, are they tubes? Do we know?
Tubes.
Tubes, yeah, the tubes. So the tandem and ovoids, what isotope is used for tandem and ovoids now? Pardon? I'm sorry, I can't hear you.
Is it the one that starts with a P?
P? No. It can be cesium. It can be iridium. She's looking it up.
Iridium.
Iridium, yeah, okay. It used to be cesium, but now it's iridium. Okay, so, stepping on from that, you remember me telling you about point A with gynae? So where is point A? Point A defined as? Point A is the dose, where the dose is to. You remember what point A is?
Point A is on the tandem.
Pardon?
Point A is on the tandem, right?
Yeah.
And then B is on the ovoid.
Well, yeah. How far away from the middle line is point A? Anybody help her out here?
I'm just gonna guess 2C.
Anybody? No?
I give up. I'm asking a friend.
2 centimeters.
Oh.
You should.
2 centimeters. 2 centimeters from the middle line. So there's also 2 centimeters cephalad, which is above, from the external cervical os, and 2 centimeters lateral to the patient's midline. And you're right, point B is 5 centimeters lateral. Ophthalmic plaque. Nobody's probably seen one of those. Can be destructive for use with what kind of isotope?
You said ophthalmic what?
Plaque. Disc. Ophthalmic disc. So there are several you can use. The answer to this one I'll give you, it is all of the above. So cobalt has been used, but not very often. Iodine 125, iridium 192, and ruthenium 106.
What was the question again?
Cobalt.
And what was the question, what was your?
Oh, sorry. Ophthalmic plaques can be constructed for use with. Okay, so permanent implants, the ones we use for, the most common is prostate. Why are they selected? Why is the isotope that they use selected? Is it because of the durability? Is it because of the specific activity? Half-life or half-value thickness or half-life? Why are they chosen? Half-life. Because if you have a prostate gentleman and you put something with a long half-life in them, they're wandering around with this long half-life isotope, which means that they can't get close to pregnant women, small children, go through airports very easily. So it's half-life. Almost done. Surface molds. They are used, they can be used to treat certain disease sites. I'm going to give you 4. We're looking for the odd one out, the one that could not or should not be treated with a surface mold. Everybody know what I mean by a surface mold? Does anybody know what I mean by a surface mold? Can anybody guess what I mean by a surface mold? It's a radioactive, they're usually radioactive seeds or tubes. They're put on to an applicator, which is placed on the surface of the skin. So it's to treat either a skin lesion or a subcutaneous lesion. That makes some sense. Okay, so surface molds can be used to treat all of the following except a deep-seated tumor in the pelvic sidewall, a lesion on the hard palate, a lesion in the excentrated orbit, and a 1 centimeter deep lesion in the preauricular region.
A.
Pardon?
A.
A. Why? Why? You're right.
Because it's a deep-seated pelvic.
Deep-seated, you had it, the deep-seated, right?
Yeah.
Yeah. So all of the other ones, yeah, you could use a surface mold. Even in the palate, you could put a little thing in there. So, if you had to handle radioactive sources, long-handled implements must be used. Why? So I'll give you 4 answers. To reduce the time spent loading, to reduce the exposure to the hands of the loader, to increase the distance to the patient and thus reduce exposure to the patient, and improve the accuracy of loading.
Decrease time, no, it was B. What was B?
B, that's to reduce the exposure to the hands of the loader.
Yeah.
Yeah. I'll tell you a story at one point here. When we were doing HDR many years ago, we had to bring the patients to the simulator to check positioning. So when we used the tubes and ovoids, they should be straight. The tube should be here and the ovoid should be sort of in this position, right? So we got this lady from the OR, and this was before we did, I'm sorry, we didn't do the HDR on this lady. This was, we had sealed sources, live sealed sources inside the patient. Radioactive sources inside the patient. So we had to get her onto the bed, do an AP and a lateral x-ray. And we had to get the doctor to see them before we sent her back to the nursing unit. And the tube was supposed to be like that, and the ovoids would be sort of here and here. Unfortunately, the physician who put them in ended up with the tube like that, and one ovoid was here and one ovoid was here. So we called the doc, and he said, "Oh, I have to change that. I have to get them out." And we said, "Okay, we'll take her back to the theatre, the OR, and you can do it." No, I'll just do it here." And we said, "You're going to take them out here?" "Yeah, on the bed, on the simulator bed." And we thought, okay, this is going to be, so we had a pig. Remember what a pig is? Apart from the oink oink one? It's, what is it?
Stuff, radioactive.
Yeah, it's basically a box, usually on wheels. There's a lid and a very long handle. So we had the pig in the room, and we had these long handled forceps that we're supposed to use. And Dr. Lindsay was his name, strange man. And so we got this lady, and of course we've got no stirrups, so we had to sort of just put her legs up on the bed. And she's still slightly out of it, which was good. So he just takes away the packing, and he just reaches in and pulls out the ovoid. And we had the lid open, and we're standing, put it in. And he's like, what? And he's got this ovoid on this string. It's about this long string. So he's standing there with this ovoid, and we're saying, put it in there. So he puts it in there. And then he gets the other ovoid in, and he puts it in there, and then he digs for the tube, literally. He goes up, pulls the tube out, and we said, put it in the pig. What? Put it in the pig. And we slammed the door shut. And we had to get her back into the OR, and we had to get new tubes and ovoids because they were messy. There's no way we could put them back into the lady because they were bloody and gunky and all nasty. But yeah, never let anybody do that to you.
What's the reasoning he had for taking them out there instead of just taking them out where they're?
Well, actually, the reading he got in his badge, we stood well back, so we didn't get much at all. But he basically was unable to do OR for 3 weeks.
Well, so why would he choose to do that? Like
Because he was an idiot. I'm sorry, he was an idiot.
I mean, if you have to go back to the OR
Right.
anyways, it doesn't
Yeah,
seem
I
to
know,
make any
and it
sense.
just, yeah. When we told the director, because we were literally screaming at him, put them in the pig. And one of the nurses had poked her head in the door to find out what all the noise was about. And all she saw was Dr. Lindsay with this ovoid and a string, and us standing well back and saying, put them in. So she went and told the director of the department that something strange was happening in the simulator. So he came back later and said, what the hell happened in here? So we explained as politely as we could that what Dr. Lindsay had done. And he says, he used some very bad words, shall we say. And he tore him off a strip. He took him to his office, and you could hear him yelling outside of the physician's offices. And the physicist also tore him off a strip. They told him not to come back for 3 weeks at least. Because at that point, you know, if you did something really bad with radioactive sources, you had to stay out of the department for X number of weeks, or stay out of the way of sealed sources. But he got fired. Not for being an idiot, but for prinking on the job, so. Idiot.
Well, that's being an
basically.
idiot.
Yeah. Well, he was another one that he came in one day. He was very, he didn't believe people were in pain or how much patients were in pain. And as we all know, patients, some of them have got a good pain tolerance and some don't have a good pain tolerance. It all depends. And Dr. Lindsay couldn't understand why this patient couldn't move because he was in pain. He had cancer riddled on his spine. He couldn't move. So we figured out one day when Dr. Lindsay had fallen at home and came in, and his arm was sitting like this. And we said, Dr. Lindsay, what happened to you? And he said, I fell. And he said, I put my hand out to stop me. And I think I broke something. And we said, okay. He said, well, would you put me on the simulator and find out? Because I don't want to go to the emergency room. It'll take forever. And we said, okay, so we put on the simulator. And his humerus, his radius and ulna, he had done this. His radius and ulna had gone in high up, had pushed in, and his humerus, the head of humerus had gone in and displaced his clavicle. And we looked at this film and we thought, ooh. And we said, are you sure you're okay? And he said, oh yeah, it's a little sore, but it's not too bad. Yeah, okay. So we called Keith Arthur, Dr. Arthur. And he came in and said, what happened is Dr. Lindsay fell at home. And do you know what he was doing when he fell at home? And we said, no, we got a fairly good idea, but not up to us to say. Uh-huh. Do you take an x-ray? Mm-hmm. What does it look like? And we flipped the view screen, the light box, and I won't repeat what he said. And he said, okay, I'll take him over to the ER. So off he went. And he had to go home he had surgery done. And he had fallen because he was drunk. But it's not because he was drunk that he didn't feel the pain. He felt the pain because he didn't feel the pain because he had an extremely high pain threshold, and that's why we figured that out. Anyway, to get back to more mundane stuff, so I need all of your comps by the end of the semester. The last day of class will be next Monday. The last day of clinical will be the